There you go. Okay. COPD. Up to this point in time, we've kind of classified, described what the pathology is, what the pathophysiology is, clinical manifestations, and then we're going to talk about how do we manage this patient. And there's really a couple different aspects to this. The biggest part is that we want to prevent exacerbations. We don't want them to have to come back into the hospital again. So all of this is going to be focused around that part. One component is obviously to assess and monitor it and be able to evaluate the progression of the disease if it's still in an evolving process, or to see where they're at. So this is why we were going to do spirometry on these people sequentially. Okay? We're going to reduce risk factors. Certainly stopping smoking is one key component of that, but also doing things like the pneumococcal vaccine, the influenza vaccine, because those contraction of those infections can trigger an exacerbation. Managing stable COPD by improving exercise tolerance. We're going to find pulmonary rehab as a real key component of this. The inactivity that exists secondary to the breathlessness associated with exercise will only lead to further deterioration. So we need to get them back managing themselves effectively, and hopefully in the process reduce more mortality. Smoking cessation, these are the 5 A's that they talk about. Always ask the patient at every visit if they've stopped, and if not, advise them that they strongly should quit. Assess willingness to attempt, because again, unless the person wants to quit, they're not going to quit. And assist the patient in quitting by going through and utilizing either nicotine replacement therapy, utilizing drugs that might inhibit or kill the urge to smoke, and then arrange for some follow-up in the process. All right, you have this blown up in the back, and what you should expect on the test is a scenario where I give you some patient data, and you'll need to, I may ask you, how is this COPD classified? Mild, moderate, severe, very severe. I might ask you what therapy would be appropriate for this patient, and depending upon the stage they're at, the gold standards have different recommendations. So know this. Okay? Because that's really how we manage COPD, or how it should be managed. And if not, just like we'll find out when we look at the asthma guidelines, these are not Rick Sahatnik's wonderful little rules. This is what the expert panel says should be done for managing. This is the ATS and the ACCP and the European Thoracic Society, what their recommendations are for how this patient should be managed. So again, mild, the key part is that we're just looking at prevention by vaccination, by getting the flu vaccine, getting the pneumococcal vaccine, and having a rescue short-acting beta agonist available. So that's SABA that we talked about. Stage 2 is now when we're starting to see the FEV1 less than 80% predicted, but it's above 50%. So not only are we going to do that, we're also going to add a LABA along with that process, so a long-acting beta agonist. And this is where we should consider also pulmonary rehab. Stage 3 is when it's between 30 and 50% are predicted, and we're going to add to those first two things an inhaled glucocorticosteroid, especially if we're seeing repeated exacerbations, which chances are by that point in time you will see an exacerbation that requires a hospitalization or at least an ER visit. And in the very severe, where it's less than 30% or less than 50% with CO2 elevation, we're going to add long-term oxygen therapy and consider surgical treatments. Yes?
Do we need to know LABAs and
For right now, you need to know the LABA and the SABA, but not the individual drugs yet, because they haven't covered it in pharmacology yet. So, but eventually, you'll eventually know that we want to add a long-acting beta agonist like formoterol, perhaps combined with a glucocorticosteroid like what's it called? Mometazone as a long-term agent. So, anyway, we'll get there eventually. As far as oxygen therapy, usually it's just a low-flow oxygen, although it can also be an air entrainment mask, so we have a fixed concentration as their tidal volume and respiratory rate vary and the respiratory pattern varies. Concentration of oxygen will stay constant. This has been documented, and these are both very old studies, but the MRC was in Britain, and the nocturnal oxygen therapy trial was in the United States. And this is the MRC, and you can see that patients had oxygen at night had a longer patient surviving. So patients who had oxygen at night versus patients who did not have oxygen at night, as time went on, they ended up having better mortality. Okay, and the one that was in the United States was called the nocturnal oxygen therapy trial, and the same kind of idea. So the presence or the ability to prescribe oxygen to these folks, even if it's only at night, prolongs mortality or prolongs life. Doesn't prolong mortality. It would be a bad thing, wouldn't it? Yeah. Even if they're not using the oxygen during the day, certainly using it at night. And part of that, I'm sorry, I said this one wrong. This is one where they were using it 24 hours. The British study was only looking at nocturnal. The U.S. study was looking at 24-hour oxygen therapy, and that actually showed even more improvement in mortality. Bottom line is that a lot of times patients will feel that, oh, I don't want to have oxygen because I'll become addicted to it. No, you do. Beth wears glasses. Why does Beth wear glasses? So she can see. You're addicted to glasses, that's right. I have to have them or I can't see. Oxygen is the same exact way. There's no reason. You're giving the oxygen to restore the deficit that is present. It's not that you're becoming addicted to anything, it's just that you need it to survive. Can't make rash judgments, or you can't make rational judgments when you're hypoxemic. Your brain doesn't work that way. Okay, so 24 hours is definitely better. Nocturnal oxygen is good. 24 hours is probably better, especially if they're demonstrating it. This is us looking at IQ and showing that you can actually think better when you're on oxygen therapy. What a novel idea. Okay. And where we'll see this, by the way, in the hospital is we'll go in to give the patient a breathing treatment first thing in the morning, and they're squirrely, they're goofy. And then you come back in the afternoon and they're a little bit better. Well, part of that is when they sleep without oxygen, they desaturate. We all desaturate to some extent. They desaturate to a large extent. So that when we first wake them up in the morning, they're not all there. As the day progresses and their saturations rise, then they become a little bit better. So you'll end up seeing them.
Why aren't they on oxygen?
They might not have worn it at night.
Oh, well, they could have just
taken it off, yeah. You can't, you know, as much as I'd like to, you can't suture the nasal cannula onto patients. Duct tape? Yeah, that might work. We know that aggressive oxygen therapy can lead to progressive hypercapnia. So, and as far as why it happens, I'm not going to go there, but just the bottom line is that in select groups of patients, in select groups of COPD patients, giving them aggressive oxygen therapy could lead to problems because they hypoventilate further. Okay. So ideally, you just need a PO2 of 60. Keep them in that 60 range. We know we're at a saturation of 90. Everything's fine.
What's up with him?
He's on oxygen.
Oh, yeah.
It's called a scoop, and Mary will talk about it. But it's a small catheter that's placed into the trachea and delivers oxygen that way. So he doesn't have to worry about having that. Well, no, but just as far as the image that people have when they're on oxygen. This, what's that?
I don't think that's his only image.
You don't like his glasses?
Well, in here, you can't see his trace.
Yeah, I realize that.
Yeah. But it's domestic during the accident, right?
Yes.
Because a lot of patients say they don't want to wear it.
Hold on, guys. It makes him look old?
They hate
Yeah,
that. And they
it
don't
does.
So that's cool, but he's supposed to wear the pack.
He still has to have the oxygen source, yeah. Now, the delivery of oxygen, and when Mary gets to this part, when she talks about oxygen therapy, she talks about home therapy. It used to be that everybody had these big bulky cylinders that they dragged behind them. They've actually got systems now that are liquid. We talked about that, I think, in 1060, the liquid oxygen. And they also have now portable compressors, battery-powered concentrators that will extract oxygen out of the air and deliver it. And they're FAA approved to go on planes, which was huge.
How little or
Drag wheel behind them.
They
Yeah.
advertise those on TV now, just like they do the
Huh?
Procedures like that, doesn't like increase your risk of other issues?
Well, I mean, there's always an infection issue that is there because it's an open sore, but it's actually a very small catheter, and it's not as bad as you would think. So, qualifications for home O2 you should know. A resting oxygen arterial level of 55 or an arterial saturation of 88. Less than that is considered a qualification for home O2. You can qualify when it's below 60 if you have some other comorbidities like heart failure, cor pulmonale, or high hematocrit. Okay. In addition, we may be able to qualify patients if they demonstrate desaturation during exercise. So this is where we'll do the 6-minute walk test and see the extent to which they desaturate. Okay. But those are Medicare guidelines for getting it, and since most third-party payers use Medicare's guidelines, that's pretty much anybody. Other things that we can look at, managing their diet in a different fashion. It's much more difficult for them to do anything related to activities of daily living. Their oxygen consumption goes up just simply cooking. They may need more calories, but they may need more calories that are non-carbohydrate in nature. Okay? Because when you ingest carbohydrates, you create CO2 as a byproduct, and it's a one-to-one byproduct. For every molecule of oxygen, or every milliliter of oxygen that's consumed, you create 1 milliliter of CO2 into production. You're now putting a bigger CO2 load on them, which means that they have to increase their ventilation, which they can't do. Okay, so eating small meals, low-carb meals, the Atkins diet is actually perfect for them in a way. Not so much the lead-in, but certainly the low-carb management, high-fat, high-protein would work better. And there's actually a solution that they, you've seen the Cal, what it's called, the little can of, and like Ensure, yeah. There's actually one called Pomocal that's a liquid supplement that's low carb in the process.
I heard something one time, and I don't know if there's any truth to it, or somebody said if somebody has a, the hypoventilation problem, they have a lot of CO2, CO2 or can. Is it true that they should drink carbonated hot?
Doesn't matter.
Doesn't? So there's no truth to it?
Has no bearing. Medications are looking primarily to relieve symptoms. So in the case of airway problems, things like beta agonists and anticholinergics will be utilized. And as we'll find, methylxanthines is our third group. We're going to call the beta agonist front door, the anticholinergics back door, and the methylxanthine side door. You don't need to worry about that yet, but that's how we kind of talk about them, because they're working in three different ways to promote airway caliber increase. They'll often be on antibiotics, not necessarily prophylactically, but they'll end up having the need for them when an infection is present. And as you saw on the list, when you get to the stage 3, you end up having steroids added on. Yeah.
The beta agonist is front door and then,
Anticholinergics are back door,
okay,
and methylxanthines are side door.
thank you.
They come from 3 different angles. Okay. Quite often, COPD is associated with congestive heart failure, both right and left, and that's usually managed, again, with your positive inotrope like digitalis and your diuretics. And one of the methylxanthines that are commonly used are a theophylline derivative. And theophylline, if you remember from pharmacology, is one of those groups of drugs that has a high therapeutic or low therapeutic index. So they need to monitor their blood level to keep it within that 5 to 15 micrograms per liter. Very, very easy to get outside that range and get into the toxic state. This is just kind of showing what's going on with the respiratory muscles, especially since they use their accessory muscles, which are less efficient than the diaphragm. Normally, as we increase our minute ventilation, we increase our oxygen consumption, but it's really almost a linear rise. In their case, it's an exponential rise. So that very small increases in minute ventilation require a very large increase in oxygen consumption. So they tire and they become dyspneic very quickly when they exercise. And the goal of pulmonary rehab is to move that line down so they become much more efficient in the use of their muscles. Lots of secretions. That's one of the key facets, especially with the chronic bronchitis component of it. And when we talk about when we talk about some of these drugs and some of these therapies, they're all of them. The goal is to make the mucus that is present as easy to expectorate as possible. So simply adding fluid intake can promote that. But again, they also are prone to heart failure, so it's a fine line you're walking. They're trying to hydrate them, but not overhydrate them. Using various techniques like chest physical therapy and postural drainage, and we'll talk about, or Mary will talk about those at a later point, or deep breathing and coughing, breathing exercises, suctioning. Those are all things which help to mobilize secretions. Okay, and we'll talk more about them as we come across the individual agents. Oh, I have there no antitussives. These are the people that you probably wouldn't want to suppress a cough on. The cough is a good thing. The cough mobilizes secretions. Even though it's irritating, you really need to have it there. Whenever we have that acute ventilatory failure superimposed on that chronic ventilatory failure, CO2 is chronically elevated anyways, and now it's elevated further. It's a patient that we might need to look at doing mechanical ventilation. These people respond very nicely to non-invasive ventilation, or what we're going to call BiPAP, B-I-P-A-P, meaning that it's got 2 levels of pressure instead of just one. And they respond during acute exacerbations very wonderfully in the ER. Invasive ventilation, I think we talked about when we talked about Module B. These patients have a prolonged expiratory time, okay, or they need a prolonged expiratory time. So high respiratory rates will promote air trapping because I'm shortening the expiratory time. So you want to monitor for that. And they're very prone for things like those blebs and bullae tearing and creating a pneumothorax. So we're going to use small tidal volumes, short inspiratory times, and long expiratory times when we ventilate them. Yeah?
How do they treat the jets and buildings?
They can be surgically removed if they're large enough. That's one of the things when we talk about on that sheet talking about surgical interventions. That's one that can be utilized as a blebectomy or a bullectomy, physically going in and removing those structures. They'll just remove that segmental bronchi and tie it off. Yeah. One of the other therapies, I don't know if I mention it. Yeah, I got to hold on to that thought. But yeah, they just cut it off and pull it out.
But without the surgery, is there a needle bait?
Not that I'm aware of. They can do some of this stuff without having to go as an invasive. They can use a video-assisted thoracic. Yeah. So there's ways they can do it without going through the whole open the chest up completely kind of a process. Sedatives, especially things like morphine, can run into problems because they suppress the respiratory drive and they can become profoundly hypercapnic. So we don't want to sedate them if we can help it. These are the folks that are going to need to be managed by a durable medical equipment, the DME company. So there's all kind of home care associated with that. And we talked about the streptococcal vaccine and the influenza vaccine. The streptococcal is a 5-year, and the influenza is an annual one, as you're all well aware of, or will be. Treatment, again, includes patient education. That should be also part of that pulmonary rehab program. Looking at avoidance of infections, avoidance of triggers that might worsen or promote that exacerbation. There is a drug called Aralast that for that panlobular emphysema that is genetic in nature. It can, where you end up having that alpha-1 protease deficiency, it can go ahead and replace that. And then the other one is the lung reduction surgery. There's some patients, and it's not all patients with severe COPD, but some patients are candidates for removal of part of their lung. So the parts that are extremely emphysematous, they can go in and remove that part, and actually their FEV1 will improve secondary to that. So it's not all of them though. And then there's things like endobronchial valves, which are relatively new, that allow gas to exit but not enter. So it's a one-way valve that promotes the reduction in hyperinflation that you might see. And then finally, lung transplantation that probably is reserved more for the panlobular than the central lobular, but as a end stage. And this is just kind of the cycle that ends up happening. A patient with COPD is dyspneic because they're immobile. Because they're immobile, they don't have any fitness. Because they don't have fitness, they become more dyspneic. Because they're immobile, they become socially isolated, which makes them depressed, which makes them shorter. It just goes on and on and on and on. And yeah, it's a sad story. Okay. Let me go ahead and do another clinical sim then, if that sounds okay. Beachin. Any questions on COPD? Since that's, I will, you'll probably never see a COPD patient. Okay. Okay, since it's probably difficult to read, let me read it for you. You're an evening shift therapist on a surgical floor, 350-bed hospital. You receive a report on Ken Payne. He's 72 years old, 141 pounds, 5 feet 8 inches. You're told Mr. Payne has a recent post-surgical colectomy. You're also told that Mr. Payne has been reluctant to get out of bed since his last surgery and is currently receiving oxygen therapy via nasal cannula 1 liter per minute. He's also on Theodore, 200 milligrams BID, aerosol albuterol, who isn't, and ipratropium bromide every 4 hours, and incentive spirometer every 2 hours. The chest x-ray shown is an x-ray taken on the patient on the date of admission. On the basis of this x-ray and along with some of the other information, which of the following is most likely the diagnosis that you have for him? What do you notice about the x-ray? Flattened diaphragms. Okay. Dark? Okay, so a lot of air trapping, hyperinflation, rib distances between the intercostals, very large space there. Okay. I will tell you that Theodore is a theophylline-based drug. Okay, so it's one of the side doors. Albuterol is a front door, and ipratropium bromide or Atroven is a back door. So and this is what he's on. So what's our diagnosis? Do you think? Emphysema. Woo-hoo. Prior to the patient's room, you would review which of the following in the patient's medical chart. Current physician orders? Yes. Sounds reasonable. Past medical history? Yes. Past and current respiratory modalities? Yes. Laboratory data? Yes. Code status? Yes. Availability of health insurance? EKGs? You're still going to do it regardless of what his insurance is.
No, but didn't you say like part of that your path of treatment depends on cost?
I mean, are you talking about the clinical sim, or are you talking about in general?
I'm just wondering, like, as far as like when you pick procedures, you pick certain like modes of like delivery of a medication.
You usually don't have that much of a choice. So if you order an inhaled corticosteroid, the hospital's formulary probably only stacks one.
Well, everyone's like, oh, I don't have insurance.
Well, it doesn't matter when you're an inpatient. You got to treat them, yeah. EKGs, PFTs, nurses' notes, progress notes, radiology reports, past and present surgical procedures. Well, that was easy. All right, initial assessment. What would you like to assess? Temperature? 37 degrees, normal. Heart rate? 108. Heart sounds? Very distant without murmurs. Is that what you would expect to have? Yep. Respiratory rate and pattern? 28 per minute with pursed lips. Blood pressure? 128 over 66. Sensorium? Alert Norrington. Gag reflex? Let me stick a needle or stick a tube down your throat and see if there's any. Appearance of extremities? Why? Look for clubbing. Look for swollen ankles. Noticeable digital clubbing with +2 pedal edema. Maximum inspiratory pressure? No. Have you learned the MIP yet? Did Mary go through that? MIP? MEP? I thought I saw the monitor, the manometer sitting out, so I just was wondering. You're working on it? Yeah. Well, get moving, would you? Breath sounds. By the way, this is normally done to evaluate muscle strength. We usually see it used with neuromuscular patients. So somebody who's a Guillain-Barré or myasthenia gravis who will find it's a progressive loss of muscle function. Scattered low-pitched inspiratory and expiratory wheezes. Palpation of abdomen. Let me feel your belly. Character of sputum. Tenacious, pale yellow. Area resistance. Tenacious. I love that word. Area resistance is nice to know, but it's not a bedside assessment, correct? Pupil reactions? General appearance? Anxious and diaphoretic, complaining of shortness of breath and chest tightness. Chest inspection. Let me inspect your chest there, sir. Accessory muscles? Increased AP diameter. Hypoxic drive? Not easy to test. Say it? 89%. So given this information confirms our COPD, shows a patient who's in a little bit of distress, and certainly is a little bit hypoxemic. Probably, with a SAT of 89. So then we have a decision-making screen. On the basis of your assessment, what would you recommend? Setting the O2 flow at 2 liters and administering aerosol ipratropium bromide. Administering CPAP at 5 centimeters of water with an FiO2 of 28%. Have the patient perform incentive spirometry followed by a PEP therapy. Administer oxygen 40% via Venturi mask. Administer an aerosol albuterol Ventolin treatment. Obtain arterial blood gas and chest x-ray. Some good choices there, though, isn't there? What do you think? What's the primary problem that we end up seeing with this guy? His oxygen level's low. Why? Okay. Why is he hypoxemic? Go back to the causes. Yeah, his cause of hypoxemia is probably some elevation in his PCO2. Okay, so the key part here is the wheezing that you end up hearing. So although I want to give him oxygen, I also want to get rid of the wheezing in the process. And the problem with the first choice is that it's not as quick as the Ventolin is. Okay, so there's a couple of good choices in there. No. Choose only one. So let's go ahead and do the Ventolin treatment. Physician agrees. You now gather supplies and administer the therapy. Continue to the next section.
So you wouldn't just, first thing you do is treat that wheeze, and then if his oxygen
Doesn't improve.
oxygenation didn't improve, then
Yeah,
you'd add.
yeah. 5 minutes after therapy, he complains of shakiness and lightheadedness. You note that his pulse has essentially remained the same, but his respirations have increased to 32. What would you now do? Continue the treatment, closely observe, discontinue the treatment, reduce the dosage of albuterol and continue the treatment, allow him to rest for a few minutes and instruct him to slow his respirations and then continue the treatment. Correct answer actually is the last one. And the reason being is the reason he's got these tingles or shakiness and lightheadedness is because he's hyperventilating. So just slow down, breathe through your nose.
Doesn't that medicine also make you shaky?
Could,
Okay.
but it's probably him. The first thing I would try is something simple.
That's what you do first.
Right. For a few minutes, the respirations have returned to more normal level. He states his shakiness and lightheadedness are gone. You can continue the treatment without complications. I've done this once before, I think, so I don't know which way it's going. As conditions improve and he appears to be breathing without difficulty, you would now evaluate which of the following. Temperature. Again, vital signs usually, almost always are selections. Heart rate. It's 108 before, it's 98 now. Heart sounds. No change. Respiratory rate. Herring-Brewer reflex. No. Blood pressure. Nah. MIP, we're going to skip again. Peripheral perfusion. Yep. Adequate. Pedal edema. No change. Vital capacity. Let's hold off on that. O2 sat. It was 89% before. It's now 91. Woohoo! Breath sounds. Improved aeration with few scattered crackles. Character of sputum and production. During therapy, patient expectorated approximately 3 cc's of tenacious yellow-green sputum. Yum, 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 yum. Yum, 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 yum. Arterial blood gas. Oh, not done. I'm sorry. I clicked that one by accident. I don't know. I need to check something here, though.